So good afternoon, everybody. I will continue now on the lecture about mortality. And so we stopped here, starting on neonatal and post-neonatal mortality rates. But in the last class, I mentioned about vaccinations. The improvement in vaccinations has been something really important in the prevention of diseases. And I mentioned an article saying that there is a lot of debate nowadays without any scientific proof that vaccinations could increase the chances of people developing autism later in life. And then I actually already had in our website, this is our website under the mortality topic. I had mentioned that there was this New York's article about child mortality and also about the life expectancy decreasing in the US because of the drug overdose issue that's going on in the country. And because of that, we have a decrease in life expectancy since 2014. This documentary, Netflix, it's about Bill Gates, but the part one kind of shows concerns of providing better sanitation to developing countries. So that's an interesting documentary to watch if you have access to Netflix. These are the examples of standardization that I showed you in the Excel file and also live table in Excel. And under these extra readings, there are they are compressed, a series of different papers in PDF format. And one of them is this paper about the measles, mumps, and rubella vaccination. And the difficult thing about knowing whether vaccination can cause autism later in life is that you need to follow the same people over time. You pretty much have to have a longitudinal database in order to follow the same children who got vaccines and see if later in life they had more chances of developing autism or having autism compared to other children. And this data here is from Denmark, and it's exactly longitudinal data that's analyzed. So children that are born in between 1999 and 2010, they are followed from year one of age until 2013, so for some years. And pretty much what this study is saying is that the study strongly supports that the measles, mumps, and rubella vaccination does not increase the risk of autism, does not trigger autism in susceptible children, and is not associated with clustering of autism cases after vaccination. So all these conspiracy theories that we hear nowadays about all these different topics, they're easy to spread, even though there is no data supporting them. And the difficult thing is that in order to have really reliable data to make the counter-argument against these conspiracy theories is that you have to have really good data. And then we kind of walk backwards. But this paper here, using Danish data, it's really interesting to show that following the same children for a few years during age 1, 2, 3, 4, they do not have higher risk of autism if they get vaccinated. So the full paper is available in our course website. So now, just continuing on the lecture about mortality. So good, yeah, so you guys can ask me questions on the chat. It seems that appears now on the screen today. It varies every day. So we talked about the infant mortality rate, and we also have the neonatal and post-neonatal mortality rates. The infant mortality rate is pretty much the number of children that die before reaching age 1, divided by the total number of births in a specific country or in a specific region in a specific year. And we can subdivide the infant mortality rate into the neonatal mortality rate and the post-neonatal mortality rate. The neonatal mortality rate are pretty much the deaths of babies aged 28 days or less, divided by the number of live births in a specific place in a specific year, multiplied by 1,000. And the post-neonatal is related to deaths that happen between the 29th day of age until before the babies reach 1 year of age, divided by the number of live births, multiplied by 1,000. Why is it important to have this rate, this infant mortality rate, subdivided into the neonatal and the post-neonatal mortality rates? Because the causes of death in so earlier years of age is different than these other children here. And just to understand that, just to show you some basic data here about the neonatal mortality rates, we see that in developed regions, it's much lower than in developing regions. So in more developed countries, it's only 8 deaths of children dying up to the 28th day of age out of 1,000 live births, and it decreased to 3 between 1990 and 2013, so a decline of 55%. In developed regions, you still see high levels. And overall, you see that the number of neonatal deaths is still high if you consider all these developed regions altogether, pretty much 4.5 million back in 1990 and 2.7 million back in 2013. And then you have all these variations here through these regions within the developing countries. And you see that in sub-Saharan Africa, the rates are much higher than in other places. And in Southern Asia, excluding India, also high. They all declined over time, but it's still in high levels. And these numbers here, this rate means around 1 million babies dying up to the age of 28 days in sub-Saharan Africa in 2013, right? So why is it important to understand these two rates separated? Because the reasons of babies dying really, really early in their lives and a little later, they are related to the different causes of death. And they are pretty much classified between these endogenous and exogenous causes of death. Endogenous cause of death in an infant can occur because of genetic issues or conditions associated with fetal development or the birth process. So this is usually more related to biology, to genetic issues, and really related to the process of birth, really related to the development of the baby within the woman's body. Exogenous cause of death is due mainly to environmental or external factors, such as infections or accidents. So it's more related to the society where these babies are being born, right? So in the case of the neonatal deaths, the main causes of neonatal deaths are endogenous conditions. So it's more related to genetic causes, congenital malformations, chromosomal abnormalities, complications of delivery, low birth weight, and genetic disorders. However, endogenous causes dominate infant mortality mainly in the really, really early days of life. And we're going to talk about this in the next slides. And not the entire first month, because the neonatal deaths is related to babies dying up to day 28. But these endogenous conditions related to genetic causes, they are actually even more important, or the mainly causes of death of these babies really, really early in their life, like in the first week of life, and not for the entire first month of life. In the case of causes of post-neonatal deaths, the rate was 18 per 1,000 live births in the world in 2013, and the rate was really much lower. Instead of 18, the average of the whole world, only 2 in developed countries. And deaths in post-neonatal in the post-neonatal period between the 29th day of age until before the baby reaches 1 year of age, the main causes of death are related to exogenous causes: infectious disease, accidents, injury. So if we improve the society in terms of living standards, better health care, and public health programs, you have greater effects on exogenous causes, then a greater effect on post-neonatal deaths than on, then it's spelled wrong here, than on endogenous causes. Endogenous causes related to neonatal deaths. So if we improve living conditions, healthcare, public health, that's going to have more impact on post-neonatal deaths than on neonatal deaths, okay? We also have another rate called the stillbirth rate. In stillbirth is a fetus not born alive and is not registered as a death. So this includes miscarriages and fetal deaths. And stillbirths, how do you calculate the stillbirth rate, the SBR? The SBR is calculated as the number of stillbirths divided by the total number of births in that specific region, that specific year, plus stillbirths multiplied by 1,000. So the denominator of the rate is live birth plus stillbirths, and the numerator stillbirths, and then you multiply everything by 1,000. Stillbirths are often identified in hospital reports dealing with obstetric procedures. That's how it's usually seen in these hospital reports. The World Health Organization mentions that interventions can be plain if we know at what point before birth the fetus died. So there are some interventions that can be done. And just to give an idea, 2.6 million stillbirths were estimated to have happened in the world in 2009. And calculating the rate, the stillbirth rate was 18.9 stillbirths per 1,000 live births plus stillbirths, okay? And I mentioned to you, the endogenous causes related to genetic causes of deaths of babies, they are the main causes in the neonatal deaths. But I also mentioned that it's not in the same chances and these genetic causes do not affect the entire first month of life in the same pace, in the same level. And that's why it's also important to understand what the perinatal mortality rate is. So this rate relates to stillbirths and deaths of babies who lived for only 7 days or less, divided by the number of live births plus stillbirths in a specific region, in a specific year, multiplied by 1,000. And endogenous causes of mortality in the first week after birth are similar to the causes of stillbirth. So the reasons that we have stillbirth, which is measured by the previous rate that I mentioned, the causes of stillbirth is also related to endogenous causes, and it's the main causes of babies dying also in the first 7 days of life. And these endogenous causes are even more prominent in the first 7 days than in the first 30 days. Just to give an idea, the rate in the world was 47 stillbirths and deaths of babies who live for only 7 days or less per live birth plus stillbirths multiplied by 1,000 in the world. So it was 47 per 1,000 live births plus stillbirths. It varies a lot. In the developed world, only 10. In the less developed world, 50. And also a lot of variation in between countries. In the Czech Republic and Singapore, only 4 per 1,000 live births plus stillbirths. In Mauritania, 111. It's really high. And in the US, it declined a little bit between 2006 and 2011. All right? Another indicator that's important to understand is the maternal mortality ratio. The maternal mortality ratio measures the extent to which mothers die immediately before, during, or after giving birth because of problems associated with the pregnancy or childbirth. And the numerator is the number of deaths in a year of women, not children, of women dying as a result of complications of pregnancy, childbirth, and the conditions of the woman immediately following childbirth. But the denominator is the number of live births happening in that same region in that same year. And then instead of multiply by 1,000, you multiply by 100,000 because it is increasingly rare in developed countries. But right now, I'm just starting a research project with another professor in the sociology department. Her name is Dr. Morris. And she got all this data about maternal mortality and infant mortality from Texas, really refined data. We know where the babies died, in which hospital, and also we know in which residence women they were living at the time that they died. So we have information about hospitals and their household. And a major thing about maternal mortality ratio in the US, yeah, it's low because we are in the developed country, but it varies a lot by race ethnicity. So African American women in the US that lack good conditions in the place where they live and also don't have access to good health care, they have been experiencing high levels of maternal mortality ratio or higher levels than the other race ethnicity groups. So that's a major topic of concern in public health in the US right now, that the maternal mortality ratio has been higher than we would expect in a developed country. This is called a ratio and not a rate. And you remember that, right? Like the rate, the denominator, we would count the people that have the chance of moving to the numerator. The maternal mortality ratio is called a ratio and not a rate because the denominator is the number of live births. And the numerator is the number of women dying to complications due to pregnancy and childbirth. So these babies are not at a chance of going to the numerator. We are comparing two groups, women and children being born. So we are comparing their sizes. It's not a rate, so that's why it's a ratio. All right, that's important to know as well. And examples of maternal deaths, it was around 529,000 in 2000 and 313,000 in 2015, so it declined. In developing regions, the developing regions pretty much, they have 99% of all maternal deaths in the world based on data from 2015. And 66% of all maternal deaths in 2015 was in sub-Saharan Africa and 21% in Southern Asia, just to show that maternal mortality is really concentrated in specific countries, areas of the world. As a whole, there were 216 maternal deaths per 100,000 live births in the world in the same year, and that varied a lot across countries. Sierra Leone, 1,360 maternal deaths per 100 live births, Sub-Saharan Africa 546, US, Iran, and Hungary 21, much lower, but then you have even some countries with even lower deaths of women due to these complications on childbirth and pregnancy, like Greece, Singapore 3, and Estonia 2. What are the factors associated with maternal mortality ratio? Maternal deaths are mostly due to age, parity. What is parity? The total number of children that women have, and birth spacing. How exactly age? Younger and older women are more likely to die due to complications during the birth, the childbirth and pregnancy, compared to women in their 20s and 30s. So women in their 20s and 30s are less likely to die due to these complications. What about number of children? Women with high number of children are at higher risks of dying due to complications in childbirth and pregnancy. So women who have like more children throughout their lives are more likely to die to it because they're more exposed to this risk. And in terms of birth spacing, Women with short birth intervals are also at higher risk compared to women who wait some more years in between their children. So women who have like one child after the other, they are more likely to die due to these complications of childbirth and pregnancy. But other factors also associated with maternal mortality ratio, chronic disease and malnutrition, poverty, unwanted pregnancies, inadequate prenatal and obstetric care, and lack of access to a hospital. So even the living standards of a specific country, the economic development, poverty, all that is also associated with maternal death. And the next topic in the textbook is about the author. He tries to hypothesize about the future cause of mortality. Is it likely that the mortality rates will continue to fall, result in even higher levels of life expectancy than those attained by developed countries? And there are pretty much like two positions among demographers and public health researchers. One that argues that there is a limit up to what's this highest age that we can live, and the other one that argues against that there is a limit. And Dudley Poston, the author of this textbook, argues against a fixed biological maximum life expectancy, and he classifies even his view as being more optimistic. And then he tries to kind of like discuss what we should expect in these next decades and centuries based on what we have been seeing nowadays. So modern medical and public health techniques will surely bring about further reductions in mortality from the major causes. However, there is evidence since the early 1980s of mortality reversals, first in Eastern Europe and later in Sub-Saharan Africa. And just to talk a little bit about those, in Eastern Europe, why mortality has been increasing in these last decades. The possible factors include lack of preventive health programs, inadequate quality of medical services, smoking, alcohol abuse, and general neglect of individual health. And these more proximate determinants of mortality are caused by these more general changes that are going on in these countries. So lack of life choices under the former communist regimes. It's one of the things related to even their conditions nowadays, but also unemployment, relative deprivation, and inability to cope with economic challenges of the capitalist regime is another factor that is associated with all these more proximate determinants of mortality that's making mortality increase more in Eastern Europe. And in Sub-Saharan Africa, the AIDS epidemic has halted or even reversed gains in life expectancy in many of the Sub-Saharan African countries. So the AIDS epidemic really causing that mortality to increase and then life expectancy to decrease. The degenerative diseases are the major causes of death in the developed world. Future improvements in the treatment of these diseases is likely to happen. However, if we eliminate a specific degenerative disease, it actually would result in a really small increase later on life expectancy, because most of the people dying due to degenerative diseases are already older individuals, right? So eliminating heart disease would raise life expectancy in the US by 5 years on average. And eliminating cancer would raise by 3 years. Of course, those would be great developments in medicine, but in terms of life expectancy, we don't gain as much. We gain more on life expectancy if we tackle deaths in younger ages, right? And actually, this is interesting because now that we have the pandemic, the COVID-19 pandemic is affecting, in terms of deaths, more older people. But also in developing countries, younger people have been dying as well, and even in developed countries. So there are some estimations already by public health researchers and demographers that show that the current pandemic will also have effects on declining life expectancy, right? And he kind of mentions like the important question is not will life expectancy increase, but by how much? And that's a harder exercise to do, and that's an open topic. And with all these variations, like now we are living this pandemic, we has this issue, the opioid crisis that we had in the US, just the company who was just found guilty to provide all these different medicines that made all these people addicted to the opioid was finally indicted and found guilty, and they plead guilty on the process, and they will pay billions to the government and to the victims or to the families of the victims. And so all these things are going on right now, and that opioid crisis, as I mentioned before, had an effect on life expectancy in the US since in 2014. And that's related to that article that's available in the course website. And now I'm just updating. This is the table that I showed to you guys in our first lecture in the class back in August 24th, data from August 24th, 2020. And the US at that time had 181 deaths due to the coronavirus pandemic. And data from October 20th increased from 180 to more than 225 deaths right now. And these are this data here is sorted by the countries that have more number of deaths, and Brazil is also in really high levels, and India as well. And even when you take into account the rate, you divide these deaths by the population and you multiply by 1 million, the rate in the US, it's really high, even higher in Brazil, considering the size of this population. So you pretty much get the number of deaths divided by the population, multiplied by 1 million, you get this rate here, all right? So one important thing, that same Professor Cohen from University of Maryland that I mentioned before, he did some estimates of COVID deaths per 100,000 people in the US. And he did it by race, ethnicity, and age groups. And what we see, first, controlling for race, ethnicity. Older people tend to have higher rates of deaths. So these people here, those with at least 85 years of age, they are much more likely to die due to COVID-19 than people in younger ages. But another really sad information that we get from this graph is the variation by race, ethnicity. So if you control by age, just getting these older people, 85, the chances of them dying is much smaller among the white population and the Asian population in the US, and the blacks much higher. And if you get even like those between 65 and 74, 766 deaths among blacks per 100,000 population of blacks. And this data here is based on information from September 13 from the CDC. And the denominator for these formulas is from the American Community Survey from 2018. It's not exactly 2020, but that's the latest data available from the American Community Survey. So 766 deaths of black out of 100,000 black population in the US. And this number is only 240 among the white population. So something that I have been saying here before, all these demographic indicators, socioeconomic indicators, and health indicators in the US, they have huge variations by race, ethnicity. And that's really related to the need of implementing specific policies to improve the life conditions and health access of the Black, the African American population, and also the Hispanic population. Someone in the beginning of our course asked if some of the deaths related to the COVID pandemic was related to flu deaths. And this is pretty much data also based on CDC data, the Center for Disease Control and Prevention, from now early October, showing the annual deaths caused by flu and the COVID deaths caused so far in 2020 in the US. data up to October 6th. So you see 210,000 up to that time, and only 22,000 deaths due to flu in 2019. One of the major objectives of this course here is for us to don't fall into easy explanations about any of these topics that we are living right now related to demography, fertility, mortality, and migration. It's really easy to say that deaths are not happening at higher rates in the US. If you look at data, the rates are high, right? 680 deaths out of 1 million people. There is a huge issue related to race, ethnicity, related to poverty, to economic conditions of the Black population that make them more successful to die. And all these explanations without data saying that this is related to the flu in the same level, historical data, since like data from these last years, do not support that kind of information. Patrick?
In general speaking, though, I guess the difference could also be just how many people get tested for the flu versus how many people are getting tested for corona.
These are absolute numbers. These are not rates.
Okay. Oh, those are absolute numbers?
Yeah, these are annual flu deaths. These are not rates. So we are comparing here the overall number of deaths due to flus in each one of these years from 2010 to 2020. And this is the absolute number of deaths. So it's 210,000 here, because that's data up to October 6th. But in October 20, you already had 2025, and it's already higher than that, right? Because this data is already 2 days old, right? And but this is not rate. This is not. This is really for people who die and get the diagnosis why they died, and we see this huge difference on COVID-related deaths and the flu-related deaths. This is the graph of new cases. I just used the simpler graph that we have from this website. They have all these different ways to show this. We can show for several countries together. Instead of having the dates in the horizontal axis, we can align the countries by the time that the pandemic started to be higher in those countries. We can have information in log terms to see if the curve is flattening over time, all things that we discussed in the beginning of the semester. I'm showing here the simplest way, and only the US. At the beginning, if you go back to the first slides, I showed the 8 countries that had the highest number of deaths. Now I'm just showing the US. And you still, if you go to this website here, you can compare the US with other countries as well. When we first started this semester, we were around here, so the number of cases was going down. And it went down, and this is number of new cases. And it's like this rolling 7-day average that you get information from that specific day, plus the number of cases in the last 6 days, and take the average, because there is so much variation on this data. So to kind of like make them a little bit more smoother. And now we are pretty much going back or even higher values of new cases than at the beginning of the semester, our academic semester here. So we are higher than what we were before. And number of deaths, you see that it was high, and then right before the academic semester started was also had a little peak here, and then it started to decline. But then now deaths, they're kind of like stable in these last weeks and these last days up to October 20th here. But it's interesting to see these two graphs together. So, and all the sources of data, I'm putting them here. These are all different places that I look this information to kind of explain what's going on. And the next graph is from the New York Times. And these vertical dashed lines here, I put them there. So this one here is a graph about the new reported cases by day in the US, also a 7-day average, which is the average of the day and the previous 6 days. Some specific days, they have these yellow lines here that are reporting a anomaly of data collection. And But then you also have this smooth curve there that's already the average rates and kind of controlling for all this variation. And here the new reported deaths by day in the US. Why did I put these vertical lines here? And this is data from yesterday that I got at the New York Times website. Here you had a peak of new cases. And then a couple of days later, or some weeks later, you had the peak of deaths. Thereby, towards like the second half of July, you had a new peak of cases. And then some weeks later, you had some peaks of deaths. And now we are seeing an increase on number of new cases. So what should we expect? A couple of weeks after this, increase of deaths as well. And this is already going on, this increase here, and this is data from now, like little like in the second half of October. And because of Halloween and all these things that are going to happen in this next week, and people aggregated and so on, we should expect that this number of cases will keep going up. And then a few weeks later, we should expect this to go up. So all this discussion that we see in the media now about this second wave or these rates going up, it's really related to this thing here. And it's pretty much like people relaxing measures of wearing masks and social distances and so on. Arthur? Yeah, Arthur asked, like, would be interesting to know how many cases of those are related to college campus cases. And technically, younger people would be less likely to die related to the COVID pandemic, the virus, compared to older people. And yeah, and you could also break that by cases in college campuses and also by age. So that kind of data so refined like that is harder to get. But I do have some data here in a last map related to college cases, but not through time, just at the current pace, the current level. And this is the case of Texas. This is the case of Texas, the same kind of graphs that I showed before for the whole US. We had increased the number of cases like around mid-July, and then a couple of weeks later, the number of deaths increased in Texas. And by the classification of the New York Times, actually Texas is still high because the number of cases here, at least 15 new cases per day. And you see also, it's not so pronounced as the whole US, but also increasing a little more here, and related to a state that has so big, it has universities with like so many students that usually congregate more. You tend to have this increasing, and it could also relate to increase in deaths here because younger children also pass the virus to older people, right? And if you're not social distancing, not wearing masks and so on. This is to show variations through the US, also data from yesterday. From yesterday, there's the average daily cases per 100,000 people in the past week. So it is a rate. So we are getting the average daily cases divided by the population and then multiplied by 100,000. And you see that Midwest has the highest rates right now going on. But also in Texas, you see some places with higher rates. And we are like in between that here, like we are like around here. And just doing a zooming in Texas, this is also data from the New York Times. And like we are here in Brazos County, so around like 24 daily cases per 100,000 people in the past week. So this information, both of this is related to the past week, okay? And then you see some places that there's more concentrations of new cases, but this is not data through time. This is in a specific date or in a specific week, right? So we these maps don't have the component of time as the graph had. And then finally, related to what Arthur asked, colleges with coronavirus cases since the pandemic began. So I just opened this map in the New York Times and I just clicked here and then I did a screenshot. So it would show me the number of cases among college students at Texas A&M, which is actually higher than in UT. UT, I think now is 1,300. And but Texas Tech even higher than Texas A&M and so on. So you can check the specific campuses and go with the mouse and click on them just by going to this website here, right? So if you consider that's a high number, even compared to other places in the US, and even considering the fact that this class here has 71 students. Right now we have 3 students in the classroom, in a classroom that can have up to 85 students. So there is social distancing going on within campus, but not really in College Station, right? I mean, I live in a neighborhood surrounded by college students and I see parties going on and nobody wearing masks pretty much every day. Yesterday was like a really interesting party just behind my house and with like pretty much a nightclub with a tunk party going on there. So that's happening in a Wednesday random night, right? And here I'm showing you some of the websites that I collected data. The Johns Hopkins University has a really interesting website if you can check it. The wordometers, the wording data are the ones that I showed before, and the New York Times also has data, and that's related to those websites that I showed before. Some articles about like the association of coronavirus with demography, showing that in countries that have an older population, there is a higher risk of people dying. That's the case of Italy, for example, and there is a second wave going on there now in Europe. Association of coronavirus and sex. The coronavirus is killing more men than women. Some studies are already showing that. And coronavirus and politics, it has been used by different politicians around the world, including this country, of using the pandemic for political purposes. Cool. And here, so this is the article about vaccination and autism, the one that I showed at the beginning of the class today. And just going back to our course website, this article here about child mortality, and this one here about life expectancy decrease in the US related to the drug overdose. Child mortality, you can have this article here organized by the New York Times is pretty much showing some countries having really low levels of child mortality, but it's still in sub-Saharan Africa, really high levels. And this analysis is available for different years. So it's an interesting article. The New York Times has a lot of interesting articles that they summarize a lot of scientific results, and they show in these interesting maps. I showed you already another article from the New York Times showing inequality, the chance of people born in poor families, how that they might continue in poverty or increase their lives. So the New York Times organized a lot this information on their website. And this is really related to mortality rates increasing in the US in more current years and related to drug overdoses, alcohol abuse, suicides, and a diverse list of other diseases as well. So this is an interesting article that's available in our website. And the inequality, I don't know if I showed you to. A New York child mortality. Oh no, this in the race ethnicity week, the New York Times article about race and economic opportunity in the US. This is an article based on the research by professors in Harvard. And yeah, I guess I opened so much that It didn't go to this side. I want this one here. Yeah, so this is to show like people who grow up rich when they were children, what's the chance of them continue to be rich or going into poverty later in life. And this graph is broken down by race, like white men and black men. And then you see that white men, they are much more likely to continue rich, continue the condition where they grow up. And black men are much more likely to become poor afterwards, like 22% instead of 11. And that's something that's going to be in our lecture about race ethnicity. I put some graphs from this article here. And again, this is based on a research by some economists at Harvard. And I like just the way that the New York Times organized this data. This is go the other way around. People who grow up poor and the chances of continuing to be poor later in life or to becoming rich. And it varies by race, white men and black men. Those who grow up poor, like here, 9% of white men have a chance to still improve their life, become rich, and only 2% black men. And to continue poor, 32 against 49, right? And this, you have to just wait the graph to go through the whole time to know the final result. But all this material is in our course website. Now, we were expected to look at internal migration. So as I mentioned in the last class, we will jump now into international migration, and then we go back to internal migration when we finish this. Here I have some extra readings about the economic effects of immigration, focusing a lot on the US and European countries, and also some extra readings about the US Census citizenship question that the current government tried to include it, and about the southern border wall. And most of these extra readings here are op-eds written by the same author of our textbook. And this is an interview, a long interview, around 1 hour interview with the economist Esther Duflo, who won the 2019 Nobel Prize in Economics. And she discussed exactly that there's no reason to fear low-skilled immigration. Low-skilled immigrants, they do not hurt the labor market outcomes of the US-born population. And some people send me emails asking about the bonus points. As I explained in the syllabus that I just already showed here to you, we have 4 bonus points in total throughout the semester, and they will happen in random days, and there is no chance to redo them. We have done so far just 1, so we have 3 left. And today we have the quiz 13 that's going to be available at 4:30. It's going to be the same style of 2 multiple choice questions. But this class specifically, this semester is required to have at least 2 assignments that are open essay assignments related to critical thinking in our topic. So 2 of the quizzes that we're going to have in these next weeks will actually be just 1 short essay question. So 2 of these next quizzes, instead of being 2 multiple choice questions, will be 1 question, short essay question. And each one of these 2 quizzes will be worth up to 2 points. So 2 bonus points will happen after that, like throughout this short essay. And those short essay questions, you have more than 5 minutes to answer it. So I probably will give at least 15 minutes, 20 minutes to answer each one of the short essay. So we have 4 points in total, bonus points. 1 is already gone. The other 2 you're given within 2 short essay assignments. And the final one will be given also towards the end of the semester, all right? So that's, we still have 3 bonus points to go. So now the lecture about international migration. Any questions about the bonus points? All good?
That first quiz is next week?
We have a quiz today.
Is that the bonus quiz? Or?
No, that's a regular quiz. So let me just open I can open here. the syllabus. So today we have quiz 13, October 22nd. We had the first bonus quiz here. What I'm saying that sometime between here, quizzes 14 and 20, two of these quizzes between quizzes 14 and 20, instead of having two multiple choice questions, two of those will be just one essay question, and you're going to have more time to answer it, right? And it's going to be all on Canvas as well. And just to be even more clear, so we have one bonus point that was already given here. Two other bonus points will be given between quizzes 14 and 20, in which these two quizzes will be short essay. And the fourth bonus point will be given here on November 10th. So it's not even a surprise anymore that you already know about what's going to happen. Okay, so just be attentive. Don't miss classes. Don't miss the timeline to answer the quizzes. Is that clear, Patrick? Cool. So here we start the lecture about international migration. And it's subdivided. I first start talk about main definitions and concepts in international migration, the patterns of world immigration over time, and also focusing in the case of the US, the current trends and levels of immigration to the US, showing that the US is a major country receiving immigrants, and showing that undocumented immigration in the US, most of it does not happen through the southern border, but are usually people who overstay their visas, usually people who overstay their tourist visas. And related to that, there is some studies already showing that the proposed southern border wall pretty much will not work. It will just be a waste of money. And because the undocumented immigrants are coming to the US, not most of them through the southern border, but they're overstaying their visas. So if you want to be more efficient in the way they use tax pay money, you should think in another way, not waste money with the southern border wall. So it's pretty much showing that based on historical evidence, based on immigration to the US, pretty much based on science, this border wall will not work if it's ever constructed. And also, there's like a huge literature about economic effects of immigration, usually like really dominated by economists. And they're pretty much showing that low-skilled immigrants in the US do not hurt US-born immigrants who have low levels of education. Pretty much showing that when you have immigrants coming to the US with low level of education, they will work on some jobs that the US-born population doesn't want to work on those jobs. And those people with low levels of education who are US-born, they actually can move up into other better paying jobs that require better skills of language, like in terms of better knowledge of English. And they also have a better social network, know more about other job opportunities than these low-skilled immigrants. And the main message is exactly that the country, these low-skilled immigrants, they are not competing for the same jobs as low-skilled US-born people. They are complementing each other in the labor market. So the labor market has demand for all these different workers. And that's why immigration keeps happening in the US. All right. And a lot of these low-skilled immigrants are coming to the US, not through the southern border, but through visa overstayers. And even if the southern border do block some people, people will find ways to get in. And there is a major argument too that all these immigrants that are born outside of the US, they have lower crime rates and then the US-born population that goes against all the political discourse to build the wall, okay? So all these slides are already available in the website. If you want to read them beforehand, it's all there before discussing class. So major definitions that are important for us. We already saw some definitions about international migration in the chapter about theories of migration. Immigration as the number of migrants moving from one country to the other in the point of view of the country that's receiving these immigrants. And emigration is related, if you're doing the analysis of the country, sending migrants to other countries. And the first international migration of humans are believed to have happened about 60,000 years ago. And international migration is a geographical movement involving a change in residence that crosses the boundaries of two or more countries, as we discussed. International migration has both positive and negative impacts upon the areas of origin and destination. And actually, the negative impacts tend to be more in the areas of origin because a lot of these workers that are really productive, more like have better health, better education, better job skills, they tend to get out of their home countries and go to other countries. So the home countries lose this labor potential. And as I mentioned at the beginning, immigration refers to the movement of people to a new country for the purpose of establishing permanent residence. And an immigrant is a person who crosses an international boundary with the intention to live permanently in a new country. So immigration is then when I'm analyzing international migration from the point of view of the receiving country. And immigration refers to the permanent departure of people from a country to the other. And an immigrant is a person who moves away from a country with the intention of establishing a permanent residence elsewhere. So immigration, I'm still talking about international migration, but I'm talking from the point of view of the sending country, right? Long-term immigration, in every international migration, a migrant is simultaneously an immigrant and an immigrant. So, for example, me, I'm an immigrant in the US from Brazil, and from the point of view of Brazil, I'm an immigrant from Brazil to the US. And what do we usually call a long-term immigrant? Are those that have residence established in the destination country, usually at least 1 year. So whenever you're talking about a long-term immigrant or a long-term immigration, we're talking about those immigrants that are staying in the host country at least 1 year. Long-term immigrants comprise around 3.2% of the world's population, but of course in the US, this percentage is higher. In recent decades, the number of long-term immigrants has increased from 75 million in 1964 to 232 million in 2013. And a lot of these increases also happening after 2013 has been going on in the world because of the Syrian civil war. So exactly because of the Syrian civil war, a lot of Syrians are moving to Turkey, to Lebanon, Jordan, and northern Iraq. So this number of long-term immigrants is still increasing because refugees are also considered international migrants. Another term that's important for us to understand is return migration, and some people can refer to it as re-migration, refers to return of international migrants back to their home country, back to their countries of origin. A re-migrant is an international migrant who returns back to reestablish permanent residence in his or her original country of residence. Remember the Hispanic health paradox, that usually the Hispanic population in the US on average has better health outcomes than the white population, although the Hispanic has lower socioeconomic status. And one of the reasons that people, some of the reasons related to self-selection, the more wealthy and healthy people move to the US. But we also heard about the Simon bias effect. Maybe some of these immigrants who come to the US, when they get older and they're about to die, they decide to go back to their home country and die in their home country, so their death is not counted in the US. In that case, it's one example of return migration. Immigrants who came to the US and later in their life, after they're retired or when they're in really bad health and about to die, they decide to go back to their home country. Tourist visitors are not international migrants. They are different from international migrants. Their visits to another country is usually short-term, and their visits do not involve establishing permanent residence in the destination country. So tourists are, some of these tourists, they might come to a specific country and overstay their visas and stay in that country for more than 1 year. And yes, in that case, they become international migrants, and in this case, undocumented migrants. But tourists that just come for a short visit and go back to their home country, they are not considered international migrants. Therefore, and I will discuss a little bit more about different definitions of undocumented migrants, international migrants, in that topic further along in this chapter, in this lecture. There are 4 broader immigrant groups that we can classify international migrants. Refugee and isolated, like I just mentioned, for the people getting out of Syria because of the Syrian civil war, is someone who involuntarily emigrates from his or her native country to a new country due to persecution, violence, and deprivation. So there is a huge flow of refugees now, like I just said, from Syria to Turkey to Lebanon and to Jordan. And the United Nations agency that deals with refugees, UNHCR, has really interesting websites, really being updated on a daily basis, or on a really regular basis, showing in which countries the Syrian refugees are going. And we also have been hearing about refugees coming from the northern Central America, Guatemala, Honduras, and El Salvador, coming to the US because of facing poverty and violence and crime in their home countries. So a lot of these refugees coming from Central America, from these major 3 countries, Guatemala, Honduras, and El Salvador, are also considered refugees for that. And then there is a huge dispute with the current federal government saying that these people are not refugees because they are not considering refugees because they are not facing these aspects here in their home countries, but that's against the reality of what they're facing. And the US actually signed the UN Convention accepting to be part of a country that receive refugees, but the current administration is going walking backwards on that. Another immigrant group that we can put some immigrants with similar characteristics together are migrants from a former colony. These are people who move from a decolonized country to their former imperial country, seeking better living conditions. So a lot of people living now in African countries that were colonized previously by European countries, they exactly because of this certain link that they have with these former colonies, they tend to move more likely to those countries because then they know former French colonies. The African countries that were formerly colonized by France, these people speak French, so they would have better chances of getting a job in France. So it creates these links, Portugal, Spain, and so on, that happens from former colonies in other continents as well, not just from Africa. An economic migrant is someone who voluntarily moves to live in a destination country for economic reasons. That's more related to most of immigrants coming to the US. They come to the US voluntarily because here they see better economic conditions for them to improve their lives. And another group is an ethnic privileged migrant who is a descendant of a nation's ethnic core group living outside of the mother country for generations. So this happened a lot, for example, in South America. A lot of Europeans from, for example, Germany, France, they decide to move to South America, not because in South America they will have better economic conditions, not because South America was their former colony, and not because they're refugees. Because those are usually more wealthy people that just want to change their lifestyle, and they move to these other countries who are usually developing countries, and they can actually over there, because of their assets, because of their wealth, they can already have a good life condition, right? So these are different ways to classify international migrants as well. And whenever you're talking about international migrants, in the US, we use a lot these terms, oh, what's the generation of migrants? Is the first, the second, or third generation? And I got this classification here from this report that organized by Waters and Pino, this material here. And this is a report, it's a 500-page report that's available in the internet for free. Let me see just if it has this one here. The Integration of Immigrants into the American Society, which was funded by the National Academy of Science. This one from 2015. If you just Google it, you can find it. And that, in that report about integration of immigrants, it has like a huge group of scientists dealing with that. And one of the things that they provide is pretty much the simple classification of immigrants. What is the first generation? It's pretty much the foreign-born population, or people born outside of the host country. In our point of view, our first generation are people born outside of the US. The 1.5th generation, it's pretty much people who are born outside of the US, but came to the US as children, those who arrived to the US up to the age of 12. Why do you get these people out of the first generation? Because when they were born outside of the US, but they came to the US as children, up to the age of 12. So they will go into school in the US, they will learn English, they won't have accents future in their lives, and they will actually experience the full American culture throughout most of their lives. So their conditions, their chances of succeed later in life in terms of socioeconomic status is higher than the first generation. So that's why we take out those who arrived to the US as children and put them in this category. And if you have more refined data about the specific age in which they entered the US, you can even disaggregate this more. The 1.25th generation are those people who were born outside of the US, but came to the US between the ages of 13 and 18. 1.5th, those who came between the ages of 6 and 12, and 1.75th, those who came between ages 0 and 5. So these people here will pretty much go all their lives into daycare and into school in the US, and they will pretty much be much closer to the second generation instead of the first generation. And what is the second generation? Are children who are born in the US, but their parents are born outside of the US. So that's exactly my children, for example. I was born in Brazil, I came to the US, I'm a first generation immigrant. My children, they were born in the US, and I'm their father, they are second generation. And if you have information specifically about the place of birth of both the father and the mother, then you can even subdivide it between the second generation and the 2.5th generation. The second generation are those children born in the US, but they have no parent born in the US. Both of their parents are born outside. The 2.5th generation, one parent is born in the US and one parent is born outside. So actually my children are 2.5th generation because I'm born outside of the US, but my wife is American. So my children are 2.5th generation, I'm first generation, and my wife is third generation. The third generation are people who are born in the US and their two parents are born in the US as well, right? So those are the different classifications that we have there. And this is something that a lot of studies refer to it, first, second, third generation. I do studies that try to see the different socioeconomic outcomes for these different generations here. And I go to present my work in some conferences, and sometimes we see all the presenters using these terms, and we think that the audience knows about it. But just to be sure, I put a slide, like a simpler slide, not so detailed slide as I have here in my presentation. And whenever I show this slide, people take pictures, exactly because that's not an easier thing that people remember really quick. So that's why I like to be really clear about these classifications, because that's something that a lot of researchers that deal with international migration cite these terms. Douglas Massey, he's a professor at Princeton University, and he is one of the most well-known demographers in the US who does studies about international migration. I will keep citing him here in this lecture about international migration. He has collected a lot of data in Mexico to understand what the reasons of people moving from Mexico to the US. He has written papers explaining the theories of migration, and actually I already cited him before in this course in the lecture about theories of demography, specifically on the theories of international migration. So that's the same Douglas Massey that we talked before. And he has some more theoretical papers that we discussed before, in which he details the different theories of migration. And then he has some more empirical papers, those that try to see which of these theories better explain the specific international migration flows. And he focuses usually on the international migration from Mexico to the US. So this is data, this is information from our textbook. They tried to Dudley Poston tried to summarize Douglas Massey laws of international migration. Immigration is a lot easier to start than to stop. Once international migration from one country is started to the other, it's really hard to try to stop it. Actions taken to restrict immigration often have the opposite effect. If you try to block immigration, increase, for example, security here in the southern border, what he saw in a lot of his papers, that actually that works in the other way, because before, Mexicans tend to come to the US, work for a while, and go back to Mexico. And after border security increased a lot at the end of the 80s, these immigrants just come and stay. And instead of just coming by themselves and going back, they come with their whole family and stay in the country. And then they start moving into all different states in the country, not staying just around the southern border. So actually, this public policies taken to restrict immigration really work the other way around based on historical data. And that I'm going to talk in more detail in the coming slides or throughout this lecture. The fundamental causes of immigration may be outside the control of policymakers, and immigrants actually understand immigration much better than politicians and academics. Because they understand immigration better than policymakers, immigrants are often able to circumvent any of these policies, restrictive policies that try to prevent them from moving from one country to the other. And I discussed before with you the association between development and migration. And I discussed also with you two sets of theories that try to explain the reasons why people move from one country to the other. This structuralist theory, which is also known as the neo-Marxist or center-periphery theory, criticized the functionalist theory. The functionalist theory is also known as the neoclassical and push-pull factors theory. So that's usually more theories that economists use a lot. The functionalist theory assumes that socioeconomic forces tend towards equilibrium through migration. So the neoclassical theory is pretty much saying, if you have countries that have higher earnings and countries that have lower earnings, people from Countries with lower earnings will move to these other countries. They will have more competition and their earnings will go down. And we will tend to this equilibrium of earnings across countries through migration. The structuralist theory says, no, it's not so simple like that. It's not so direct like that. The patterns of inequality and reasons of migration, they are much more complex. And they are international migration is influenced by patterns of disruptions, dislocations, intrinsic to the capitalist society. So they see in a different way. The functionalist theory is saying, oh, people move from one area to the other, and these areas we tend to have similar socioeconomic outcomes. The structuralist theory says it's much more complicated than that. There are historical processes, there's social network, and so on. But both of them mention that migration is related to development. More development leads to less immigration. If a country develops, then less people will leave that country. And higher development differences across areas lead to more migration. And I will continue on this in the next class, but it's pretty much that. If we increase the level of development in a specific society, it will tend to attract more people. The level of immigration increases. Countries that have really low levels of development, the people are so poor that they don't have the means or the knowledge about moving to other countries, so the levels of immigration to other countries is low. As these countries start to develop a little more, these people start to have more the means to get out, that increases. But as these countries start to get richer, then the level of immigration declines and people tend to stay. Cool? But I will continue on this topic next Tuesday. Quiz 13 is now open on Canvas. So have a great weekend, and I see you everybody on Tuesday. Thank you very much.